Hey everyone, welcome to another episode of DarshanTalks. I'm your host, Darshan Kulkarni. It's my mission to help you trust the products you depend on. And as part of that, one of those things is actually going and applying and seeing if you can actually help people. And that involves proposals. And I'm hoping that we're going to get a chance to talk about that today. I'm an attorney, I'm a pharmacist, and I help companies with FDA-regulated products. So if you think about drugs, wonder about devices, or obsess over pharmacy, this is the podcast for you. Again, I do have to state this is not intended to be legal advice, so don't look at it as such. It's also not intended to be medical writing advice, so don't look at that as such either. I do love these podcasts because they're a lot of fun. I find myself learning something new each time. So if you like what you're hearing, please like, please subscribe, please share. And I know our guest today would appreciate it if you would share because people will learn a lot and love it. Our guest today is a frequent guest of ours. We've really enjoyed having her on before, and we're excited to have her on again today. And what we're going to talk a little bit about is health literacy. And we've talked about that before, but what is that like running a small business and how has COVID affected them? So if you care about any of those issues, I look forward to you tuning in. Our guest today is the CEO of Health Literacy Media. She can be found actually at C. O'Leary at healthliteracy.media. So you should be able to find that. It's also on your screen as you speak. But our guest for today, Catina O'Leary. Hey, Catina, how are you?
I'm excellent. How are you doing?
Good. I'm excited to be here. It's now, luckily I'm in the Northeast, as you know, and it's starting to get a little less humid, which is nice, or at least it's been so this week.
Brag.
Is it humid where you are right now?
It's miserable in the Midwest. So we're reaching the point of, 95, 100-degree days every day, high humidity. My poor kids are in a soccer camp this week. They're trying to figure out how to adjust the time because it's so hot by the end of the day that they're not legally allowed to play. So they don't know what to do about this. And it's really funny because the team that managed the logistics for this tournament sort of goes all around the country to do these things, and they're not their own fields. So they've rented these fields to use, and they didn't know that they didn't have water live in the field. So they're sort of running back and forth to, big chain grocery stores to make sure they have enough water and the kids can refill bottles and all of these things because it's just miserable. So, yeah.
As a former fat kid, I have to say that I'm legally prohibited from playing soccer is my dream scenario.
My 12-year-old is sort of like, how hot does it have to be? And if it's not about the heat, my knee bothers me. And, he's got all these sort of lists. And I'm like, kid, you asked for this. 6 months ago, you wanted to do this. So here we go.
So let's talk a little bit about the fact that we're still in COVID. We're still stuck inside. How has that been for business?
It's really interesting for business. So, in February and March of last year, we started to sort of see that things were going to be complicated, and we didn't have a good indication of what was going to happen. And it was complicated and things were very concerning. And then we had all of the support from the federal government with paycheck protection and all those things that got us through the summer, which was fantastic because most of our main partners had really slowed down their decision making. So they were trying to conserve resources, particularly our pharma partners, while they figured out what they were going to have to redirect toward COVID, both internally and externally. So there was a period of just sort of a stall and unknowing. And that really went into the fall for us, which meant that from a strategic planning perspective, when we were budgeting last year, we didn't know what we should budget or what we shouldn't budget. We were having real challenges of figuring out sort of month to month what was going to be realistic. But then interestingly, starting in about November, things really started to pick up again. And, I'm hesitant to say this out to the world, but we're actually having one of the better years we've ever had now, as people have gotten back to work and sort of figured out, the pandemic may be with us for a while. However, we know how to work from home. We know how to make decisions about applying resources to this particular situation. We know what employees can do. So things have sort of gotten better. ironically. And of course, we do health communication. So there's a lot to be done around COVID communications, particularly as, so many people have been vaccinated, but not enough to keep us all safe. And we're looking at these sort of next waves. I'm in Missouri, so we're back under mask mandates now. So everybody's masking again. And we still don't have the little ones vaccinated. So the masks are even a bigger deal, obviously. But Missouri is a hot mess. So again, there's a lot to be done, a lot of work in this area. So we're excited to be part of that. It's unfortunate that this is the work we have to do, but if this is what exists in the world, we want to be part of helping be the solution.
So what I'm hearing you say is you're actually helping with addressing the issue of inadequate vaccination. Is that, and I'm not saying a particular client or anything, but that's part of the work in general you're helping with?
Sure. So we're doing, we have a handful of grants to focus on vaccine-related issues and communication around vaccine-related issues. So we're working with a couple of groups in Tennessee, in Nashville. So the state of Tennessee got a reasonable amount of resources to address vaccine hesitancy and to go into communities and have good conversations with people about what their choices are and help them figure out what's the safest choice in their individual situation. So we're supporting the messaging in those communities. We've done some work here in Missouri, but we recently received information that a large grant is funded through our partners at the University of Florida in Gainesville that'll allow us to work with 5 or 6 sites. It's still processing what the sites will be. So we'll know in the next couple of weeks who we get to work with, but it's a sort of a national collaborative to focus on these same issues. And the team there, Linda Kotler and her group at the University of Florida in Gainesville, have some great ideas about community engaged methods, including, using boats in Florida to go out and reach people and meet people truly where they are. So that's pretty exciting. We're excited about that.
That's really interesting. So what I'm hearing you say, and correct me if I'm wrong, but you're making the effort to actually meet people where they are. But one of the questions I'm trying to understand is there's so many different reasons people are saying, I don't want to take the vaccines. And if that's true, when you're trying to create a comprehensive plan to address that, how do you go about figuring what is the right tone to hit, what is the right message to hit? Because there's no way you can, with one message, hit everyone that's involved. So do you do the Pareto principle where you go 80-20, or how does that work?
Yeah, I mean, I think this is sort of classic marketing PR kind of work where you're thinking about segments of populations and you have different messages depending on where you are. So you have sort of core messages. And I think one of the things that we're learning is there's so much misinformation around COVID. So we have to figure out how to combat misinformation without being so directive and authoritative that we turn people off. So I saw something last night on one of the news stations, and right or wrong, I don't know that I agree with this point, but they mentioned that one of the main government voices around COVID was so politicized and polarized that just his voice changed people's mind in a negative way now for certain people who have not been vaccinated. So then the question is, who's the right voice, right? Who's the right voice if those voices that are so trusted aren't the right voices for certain people? So in my experience in community engaged work, what I would say is that the voices are the folks from communities, right? Like if you get people that are the trusted sources, I mean, these are old school methods when you're going to churches and schools and, city leadership and all of the people who are the sort of gatekeepers in those communities and convincing them that they need to speak to their communities about what's the healthiest choice for the people in that community. It's a different conversation, and everybody can have that sort of individual conversation armed with messages that resonate and make sense for those specific groups. So we have to create a lot of messages, certainly, because everybody has a different concern, a different worry. So there's the microchip people and the people that think it hasn't been tested long enough, and the people that, I'm reading a lot right now of people saying things like, well, my aunt, uncle, brother got, the vaccine, and, 2 days later he was in the hospital and never came out. And, that's a sort of a fundamental misunderstanding of correlation and causation. So in all likelihood, the person was exposed before they got the vaccination. All kinds of other things that were going on led to poor health and a decline. That's a different situation. But, when they're looking at it in the time sequence, the biggest and brightest thing in their head is, wow, the person got the shot and they're dead. And so, they're misattributing, but it's visceral and they believe it. And so how to help them sort of walk through that is not, a quick, postcard or a soundbite. That's a real conversation to help them understand what else was going on. How did that work? What other health conditions did the person have? And it's not necessarily their problem to figure out what happened to their family member, but it's influencing the choice that they make. So to some degree, you have to have that conversation, even if you don't have the medical facts. So you have to start to talk about science and how the vaccine works and how exposures work and what else is going on. And that's a complicated set of messages. But that's one set of problems that people are having. And they believe it strongly. I mean, the number of times I've seen this lately on my social media from people that, I know well, who are just really concerned based on their perception that something bad happened because of the vaccination. So again, we have to talk about all of those things, and they're all different messages. And we have to start. I'm a social worker by training. So how do we start from the place the person is rather than applying a message that we think might be? Because, for example, if they're not a person that's worried about a potential microchip and you start talking about that, you can obviously reinforce something that wasn't even the problem to begin with. So how do you figure out where a person is, choose and deliver the right message and move forward from that conversation?
So I've always understood the role that health literacy plays and your company plays to be more creating, crafting, drafting, and writing out the message. How often do you find yourself actually getting into these conversations to actually talk to people?
So for us, we're sort of limited. So our job is to create the messages for other people to deliver. However, part of what we also do is train the people that have the conversations on how to be health literate in their communications. So this idea of starting where the person is, active listening, really thinking about what they're saying, tailoring the message to the conversation, giving the person space to speak. We see that a lot with folks who are in the medical field who, are really directly impacted and are scared and concerned, and they have the facts and they just want people to know what they know. And so the force of their message is so strong that it can be off-putting for some people. So you really have to sort of train them to a different style and a different approach. And it's unfortunate because they ought to be able to be who they are and use the messages in the way they are. And there ought to be, we wish for respect for all of us for our relative positions. But the reality is, individuals are the expert in their own lives. They need to be able to understand it from their frame of reference, and they need to hear it in a way that they can process and understand. And that's all health literacy. So training those people, those messengers, to have conversations in ways that are acceptable and approachable and receivable, accessible, is part of what we do.
So as you're having these conversations, you're having these trainings. One of the things you mentioned is that healthcare professionals are often the people you have to almost tone down. How is that received?
So it depends, right? It depends. So, in taking this out of COVID, we have this conversation with healthcare professionals all the time about health information. So what we find is often it's really hard for doctors to change the way they communicate.
Interesting.
So doctors really are, pressed for time.
Mm-hmm.
They've got a lot going on. We've trained most physicians into sort of a mentality of, they're the responsible person who has the information and they deliver it, and a person is supposed to receive it. So for many times you have to undo that training and help them understand that, people don't always understand what you mean, and they don't always accept information with that top-down approach. And sometimes they change and sometimes they don't. Nurses are really trained to think about this. So when you start to talk to nurses, social workers as well, about these kinds of things, you're sort of rolling them back to their roots anyway, and helping them sort of remember sort of who they are and what they care about if they've gotten away from that. A lot of people haven't. A lot of people are really good about that already, so they don't need more training. We have to help them think about how they train the people around them and how they sort of continue that in a time where things are stressful. and they don't maybe have the time that they need. So how do we apply this given the context of the current environment? And then a lot of the people that we train are community health workers and folks who are coming from communities and don't have much training at all. And so the challenge here is to not take away the unique individuality of this person that helps them connect with the community as they are, but help them have the skills and the strategies to not be lost in the messaging.
So let me ask you a really basic question, because it seems so intuitive what you're doing. And when you say it, you're kind of like, well, yeah, that makes sense. But the part I don't even understand is who are, I mean, I know you said healthcare workers, but where do you get these? Are you talking about a physician working in their regular private practice and in a hospital that you're educating? Or does it tend to be public health, and therefore these are physicians working for an IH or something like that? Like, who are you educating, and when do they get the forum to engage?
Right. So all of those things. So in COVID times, there's a lot of community health setting practitioners. And so we work with a lot of clinics and folks who are going out to get their patients. And those folks come together and they're, trying to use available messages. They're trying to figure out how to have this conversation, and they're really time limited. So there are lots of sort of short webinars and conversations about how to do this. And we've been involved in many of those. I think I've mentioned before on another podcast, but Prepare St. Louis, for example, has done a really good job of this. They've put together a group of providers who represent the community, all kinds of providers, doctors and nurses and social workers, all kinds of health professionals, but they've trained them to really focus on what's the right decision for you, which is a different conversation than physicians often have. So it's different than diagnosing, but it's talking about sort of what do you need to know? What do you need to understand? What are your questions? What are your concerns? How can we work through this with you so that you can make the decision? So we've been able to support that conversation with some health literacy pieces. And then also with, our work with Nashville and other places, we've been able to sort of plug in and help people think about that. Outside of COVID, though, we do it all the time with big healthcare systems and other groups, where we help train people to have conversations that are, more health literate. We train a lot of medical students, actually. So that's one of the cool things to do is if you can train people early on in their medical training, you can really start their career on the right foot. And they haven't sort of practiced into behaviors that are less patient friendly. So that's a really nice thing. So we get to do lots of those. Last year we did them all virtual, but this year we've been able to do some face-to-face again, which is really nice. So we've had a good time doing that. So I just a couple weeks ago trained the residents at St. Louis University. And so, 100 or so of these people early career at the same time. And, all of them have good instincts. All of them are going into this for the right reasons, but a lot of people just haven't thought about it yet. So when you start to sort of ask them the questions and help them think about some of the issues, you're sort of removing a blind spot for them so that they start on the right foot. They know a lot about medicine. They don't often know a lot about insurance, which is not seemingly a big deal until you start making prescribing decisions that people can't afford or don't align with their values or their culture or other things. And so we spend a lot of time talking about that in the context of health literacy, of how do you sort of think about this person's whole life and have the right conversation so that you're, providing care for the whole person, not just sort of the one thing that you think they've presented for.
That is so fascinating, because I love the idea of getting them when they're young and talking to them and reminding them almost of why they're doing this. Because in the end, I like to believe that all of us went into healthcare to help people. Right. And sometimes somewhere along the line, it becomes a job. And that's probably when you should get out of healthcare, because or be reminded of why you're doing this again. That I think. Anyways, the question I have out of that is, when you talk to these medical students, do they, how do you find that it changes how they behave? Like, do they help you with volunteer drives and stuff, and then you see sort of that different spark in their eyes as they talk to people? Or is it more, I got this, I was always into this? Or how does that generally play itself out?
So some of both. So sometimes we have people that say this is really important, and we see them again and again, and they come and they volunteer and they do other things. They're super busy though. So a lot of times people are like, okay, this is just one tool in my sort of bag of tricks, and I'm going to apply this over and over. I think it's really important though. Years ago, I don't know, 5 or 6 years ago, we were doing a health literacy summit, and one of our speakers was a physician, also from St. Louis University. And he had done a study. He'd been spending time sort of understanding burnout in young doctors. And one of the things that he found, and he talked about a lot, is so much of the reason that doctors were starting out depressed, actually. They were starting out anxious and depressed and with serious health issues because they were disconnected from what was important to them in the first place. And so they didn't get to see patients soon enough. All of these sort of human characteristics and components of medical care had sort of been stamped out through the process of medical school. So what they found is if you could connect people back to communities and sort of give them permission to be human again and to do this work, they were stronger doctors. They were more mentally focused. They were more able to do their work. And so I think health literacy is a real important part of that. We see, we're not unique in doing this. A lot of universities have communications departments that do health literacy work. I think they're really trying hard to integrate into med school curriculum in particular. There's always a challenge because the curriculum is big and bloated already. And so where does this fit? But again, we do these little trainings that are part of orientations and things like that. And it's just a chance to sort of see them, let them know this exists. And again, it's not so hard to understand that once you help people see it, that they can't integrate it. The application can be harder. You have to practice that sometimes, but this is not the only dose that people get if it's interesting to them. If you never tell them that it's important and you never tell them that it's okay, they're never going to have that opportunity.
So that really brings you to the second question, right? Which is the idea that this tool set. Well, actually, I have two questions that come out of it. My first question is, I have no idea if you know the answer to this question, but do you find some doctors to be more open to these ideas than others? And what I'm thinking about is, I've generally thought of surgeons, and I know a ton of surgeons, and I say this with a great deal of respect to them. Surgeons tend to be very, very focused on, I want to do surgery. I'm not in I want to help people, but I'm not a public health person in general. On the other hand, I would see like a family practitioner being more, I want to work with people. There's a public health issue, and I'm there for it. Or are medical students too early in that food chain to even think about those things? And how does it all play out based on what you can tell?
So I don't ever think it's too early to start talking about being human and communicating well and being respectful of the other people in the conversation. So I'll say that to begin. But I will also say that I agree with you that by specialty, some people are better at it than others generally. Surgeons are a great example. They have so much else they have to learn to do. People don't spend a lot of time helping them learn to communicate. Some people are naturally gifted. You see some surgeons who are, department heads and things like that. Part of their other skill set has been these sort of people skills, the soft skills. Some of that transitions to patients, but for a lot of people, it really doesn't. The issue though, or the question is, as a patient, how much do you care? So when you're actually in surgery, you want the best surgeon. And if they have other people around them that communicate, maybe that's okay, perhaps. We all want to be better, but, maybe we don't have to beat surgeons up necessarily if they're not all uniquely good at being communicators. The same for, radiologists. And, there are whole groups of people that maybe make selections based on other technical skills that aren't necessarily communication. And that's okay. But we have to think about what our team looks like and who is the communicator and how do we make sure we have good conversations. A lot of family doctors, as you point out, are fantastic. My mom sees a doctor here who is just so good at this. I go to her visits with her, and every time I go, I compliment him on what a good job he does and how well he explains things. And, he's rolling around on the chair and he's drawing pictures for her and he's, pointing on her body, she's got a knee problem and sort of pointing toward the areas and explaining all the pieces. And, he goes through the same things over and over. It's documented in the chart in clear language. I mean, it's fantastic. But I've been with another family member to see a doctor in psychiatry, where you would think they would be a fantastic communicator, and get the after visit study and it's illegible, right? Like it's just completely full of jargon, completely not understandable, and so much so that I've seen the family member be upset about it because they're not able to read it, and it makes them feel like they're sicker than they are, and what does this mean? And so I don't know that it's completely related to the specialty you choose. Some of this is sort of our human characteristic as well. But, we should talk about this a lot more. We should talk about it early and often in people's careers. We should really reinforce that it's okay. It's good to be a good communicator. And in fact, as a lawyer, this, I mean, nobody wants to be sued. You're less likely to be sued if people like you, if people feel like you've listened to them, if people feel like you're understood. There are all kinds of studies about this. You can make horrible mistakes and be a caring person and not get sued. You can make really little tiny mistakes and be sued sort of embarrassingly badly because people don't like you. So, there's a reason for this skill to sort of protect your practice, to protect your time, if you don't care about being a good human. And being a good human is just, a lot of people do care about that. And I think you're right. People go into medicine generally because they care.
Yeah. So I'm going to ask one last question. As you know, we're well over our time, but I'm going to ask one last question because this time flies every single time. But these conversations, to me, are getting into that public policy discussion. And as we start getting into these public policy discussions, one of the things that starts rearing its head is the idea of social determinants of health. Are you finding that these skill sets that you're imparting are potentially leading up to, or at least enabling, the conversations in the future on what is your state in terms, you as the patient, for physicians or clinicians to have, where they're now understanding better what their patients are going through and therefore trying to address the needs of the patient where they are from a social determinants of health standpoint than if they did previously, if you will?
So that's the hypothesis, right? Like, so we believe that health literacy is a social determinant. We also believe that it's a two-sided.
I didn't know that.
Yeah.
Is it a social determinant? Okay.
It's considered a social determinant of health. So your ability on the patient side, your ability to sort of get information, either hear it, read it, learn it from your environment, take that information and use it to make your own decision, determines your health in many ways. And it's a stronger predictor than a whole bunch of other social determinants in a lot of ways. And so piece one is absolutely an individual's ability to process and use information toward their health is important. But on the other side of that, once we start to think with providers about how they communicate and how they support individuals, this is an area where they can make more change than many other social determinants, right? Like this is a really modifiable interaction. So if we train this, if we think about it, if we prioritize it, we can make a big impact for sure. Or at least that's the hypothesis. And that's what we've been doing.
Well, I'm sure we'll be seeing more and more information that supports this, but we'll find out. So our usual questions. Based on what we discussed, what would you like to ask the audience?
You know what? Every time we have this usual question, I'm always stunned by it again. I get so excited about the conversation that I forget to think about what I'd like to ask the audience. But, I think the things that are interesting to me from an audience is, where are you seeing this happen in your practice settings? So I'm assuming that most people listening here are people who are providers, they're in healthcare. There's a reason they show up here. So where's health literacy showing up? Where's it not? And is it only the writing? And, it's really easy to sort of sift this down and say, okay, well, if we get this to 6th grade reading level, everything's going to be cool. Are people having these integrated conversations about verbal communication and how we sort of situate the context of health literacy in a more meaningful and deep way?
Okay. And I usually try to answer the question. Since I don't work in a practice like that, I'm not sure I can, but we'll look for the answers that come out. My next question, what did you learn this month?
What did I learn this month? I'm going to change your question because it's not what I've learned this month, but it's what I'm excited about this month.
Sure.
I'm really excited this month about just sort of the reality that we're able to change. So I felt like most of last year I spent sort of worried and stressed and not sure what was going to happen. And I'm still worried and stressed and not sure what was going to happen. But I'm seeing groups be more flexible. I'm seeing people sort of get back to joy, and people are sort of finding ways to sort of live in this new environment that is not quite as heavy as it was before.
Yeah.
So I'm seeing people adapt in a way that I wasn't sure. I think for a long time it was like, we're either going to be like this and sort of be scared and miserable, or we're going to go back to what was before. And I'm seeing something that's completely different, that we're sort of adapting and figuring out, what's the new reality look like. And, we're finding important, important differences in how we do things.
It's funny you say that. I was actually reading like a little joke on Facebook, I think. And speaking about change, they said we really need to get rid of the idea, the saying of avoiding something like the plague, because apparently we don't.
Right.
So I just thought that was kind of funny. Last question, because by the way, everyone who wants to reach out to Catina, go to C. O'Leary at healthliteracy.media. But the last question: what made you happy this week?
Despite it being really miserably hot, I got to go swimming a couple days, and it was just really nice to be out with kids, be in the pool, sort of cool down and experience something normal. So I just said, we're not going to go back to normal, but there are these sort of peaks at normal where it's like, okay, this is a real summer. This is we can see this. We're all sort of, again, this idea of like we're having joy, and everything is not sort of scary and miserable and uncertain.
Awesome. And again, if you guys want to reach me, you can find me on DarshanTalks.com, or just go to Twitter and find me at DarshanTalks. And Catina, thank you again so much for coming on. I'm looking forward to having you on again.
Thank you. It's a fun conversation always.
Pleasure as always.